Hi everybody, it's Melissa. I'm back here in the next installment of From the Clinic to the Living Room, and tonight we're going to be talking about the immune system and immunology and the side effects and how you can identify them, how the immune system works to combat that, and what we can do about it. So it's primarily going to be managing the side effects of the checkpoint inhibitors, and those medicines include Keytruda and Opdivo and Yervoy. And in general, immunology and the immune system is a really complicated topic. I actually did a Facebook Live that you can find on my From the Clinic to the Living Room website and also on YouTube, talking just about the immune system and how these medicines actually work with the immune system. So the very abridged version of how checkpoint inhibitors and the immune system kind of interact, we're going to do first and get that kind of out of the way, and then get into the meat and potatoes of really managing these toxicities. So essentially, when your body, you can think of your immune system as this great big giant security system for your immune system. And the primary player is the T cells. They sort of walk around and survey the body, looking for things that don't belong, things that are damaged, broken things, bacteria and viruses, and cancer cells. So your body gets exposed to DNA damage all the time. Each cell in your body, hundreds and thousands of times a day, gets exposed to some type of abnormality. And the immune system's job is to identify that mutation or abnormality and get rid of it. And funny thing is, the more mutated or the more weird looking it is, the easier it is to get rid of. Unfortunately, for a lot of cancer cells, and melanoma is one of them, the immune system sometimes doesn't always recognize cancer cells. And in the very beginning of using immunotherapy to treat cancers, they were very nonspecific, and really Yervoy is a really good example, or the anti-CTLA-4 agents are a really good example of that, because they work by essentially taking the brakes off of your immune system and allowing your body to make tons and tons and tons of these fighter T cells that then go out into the body and attack tumor. So it's a very, very nonspecific response to the immune system. The second generation checkpoint inhibitors, which are the PD1 inhibitors, actually got a little bit smarter. And scientists over time kind of figured out that something was happening with the tumor and the T cells to make them ignore cancer cells. And the key to that is this PD-L1 ligand. So if you have a cancer cell, it has all these little spokes hanging off of it called ligands, and it kind of helps them identify the things in the immune environment that don't belong. So they kind of feel their way through and feel on the surface of the cancer cell and see if it belongs. And one of the ligands that they found on the T cells is called PD1. And when that ligand identifies an abnormal cell, it actually turns the immune system on to tell the T cells, let's go, we got to fight some people. Cancer cells actually have a ligand called PD-L1, and it binds to that PD-1 ligand, and it actually tells the T cell to go to sleep, take a nap, and not recognize this cancer cell. And the reason that that's important is it's how the cancer cell evades the immune system. And so what the second generation checkpoint inhibitors, or the Judy, you can't be in my video, sorry. And what the second generation checkpoint inhibitors want to do is they want to block this interaction between the T cell and the cancer cell so that they can't join up and mask themselves. And those are the anti-PD1 drugs. And so when that happens, the PD1 blocks this interaction and creates a scenario where the T cell is activated and it creates programmed cell death. So I go into that a little bit more detailed in my immunology lecture, so you should go back and watch that if you haven't. I use props, it's pretty interesting. But also after this live is over, I will post 2 videos that I actually found recently that do a really good job with graphics explaining that exact process with the PD1 inhibitors, because I think that's a little bit more difficult of an interaction to That's okay, Judy, you're fine. It's a little bit easier interaction or harder interaction to really conceptualize. But the end result is that both Yervoy, Opdivo, and Keytruda, the side effects that happen because the T cells get really upregulated and they start attacking not only the cancer cells, but also your normal cells. And so one of the things that I always try to impress upon people is that the majority of folks that get treated with these immune checkpoint inhibitors actually don't have side effects. However, they can get autoimmune toxicities, or adverse events is what we call them. Before I kind of start, I just wanted to point out that AIM actually has these really cool toxicity management worksheets that you can print out. It's I'm sure somebody from AIM is watching and they can post it. If not, I will post the link to get there. It's under the education section on our website. I printed them so you could see, but this is kind of what they look like. And this one is specifically for Keytruda, and it goes into some things like how the medicine's given, some of the problems that you might have. And the first page is sort of like a summary page, the most common side effects, and then it goes through each individual toxicity. Here's the one on skin changes, and it talks about like, what kind of things do you need to tell your doctor? What are the red flags or that indicate a more serious problem? How can you do things at home before needing your doctor necessarily, and some like over-the-counter-ish things that you can do to kind of help. So these are all available for not only the immunology, like immuno-oncology agents, checkpoint inhibitors, but also for the BRAF MEK inhibitors and some of the other medicines. So check those out. They're really, really helpful. And they're kind of a good starting point, not only for you at home, but also knowing the things that you want to keep track of to tell your doctor. So they're important. So when these adverse events happen, they can happen really at any time during or after treatment. And this is especially true with the anti-CTLA-4 with Yervoy, because the half-life of that drug is really long. So it stays in your system for a very long time. Months, if not even a year after, you can still see the adverse events appear. Keytruda and Opdivo, that half-life is a lot shorter, so these side effects after you're done with treatment don't tend to happen quite as delayed, but they can. So one of the things that providers especially need to keep in mind, but also patients, is that you need to keep these mindfully in the back of your mind, that if you're having any of these toxicities that we kind of talk about, you don't forget that they could be potentially from your immunotherapy. So there are some things that happen earlier on in treatment and some things that happen a little bit later. The things that tend to, or the body systems that tend to be affected first, and that's usually within the first, two cycles, they appear quite quickly, are things like skin changes, rashes, dry skin. It can be a rash that itches, or it can be a rash that doesn't itch but is just present. As that sort of autoimmune process in the skin progresses, you can develop things like skin peeling and ulcerations, sores in your mouth. Those are really an indication of a really serious problem, and something that you would probably need to be hospitalized and on IV steroids. We'll get to the management of these kind of later at the end, overall as a group, just because they're all managed in grade 2 and 3 and 4 with steroids. So there are very specific guidelines. ASCO, the NCCN, they all have these very specific guidelines that they set in place for immuno-oncology and for these inhibitors, just because they want to make sure that oncologists, not only in an academic, in big centers, but also in community centers, have access to these guidelines so that the toxicities are being managed appropriately. Because truly, if you manage these adverse events correctly, there's really not a ton of danger for patients. The serious adverse events where you see deaths and life-changing toxicities really happen in a very small population of patients. and it's kind of a combination of two things. One, not being managed appropriately and quickly enough with the steroids, and two, things not being identified either at a doctor or patient level to be able to intervene at its earliest appearance. So we'll talk about the management kind of clear at the end, but let's go back to skin, because that's the most early change that you can see. We always try to encourage patients to take care of their skin, moisturize. If your skin is itchy, take cooler showers, because that will help not dilate the blood vessels on the skin, which allows you to be less itchy. If there's a particular patch that's extremely itchy, we will sometimes tell patients to put cool compresses on that patch, because the same effect happens. The cooling will certainly calm that area down and make it less itchy. As an immune response, we want to avoid using like fragrance soaps. So use boring soaps and cleansers like Cetaphil. And also same thing with lotions. You want to use things that are non-fragrance like Lubriderm, CeraVe. Cetaphil also has a lotion. Gold Bond Ultra Healing Lotion is a really great one, especially if the skin rash is causing a lot of dry skin. Making sure that we keep our fingernails nice and short to avoid scratching. If none of these, one of the other things that we do actually use quite a bit is our antihistamines, but not only just Benadryl, but taking daily Claritin or Zyrtec or Allegra. We don't discriminate when it comes to antihistamines. Whichever one tends to work best for you, that's okay. You can take that one. Generics are fine. But we tell people to take a daily antihistamine because it really does help with that itching a lot of the times, especially in the earlier appearance of the skin toxicities. So if all of these sort of over-the-counter managements don't work and the rash continues to spread or becomes more itchy, we'll oftentimes use topical steroids that are prescription strength that your doctor can write for you. Some of the most common ones are betamethasone and triamcinolone. They're definitely ones that you will need a prescription for. If the rash spreads past the point where you would need to dip your entire body into a vat of steroid cream, then we would move on to a low dose of oral steroids. And most of the time doing between 30 and 40 milligrams of prednisone a day will take care of these skin rashes. Now, if the rash continues to progress, it's not managed appropriately, sometimes you just get those patients in 1 to 2% that their rash just isn't very well managed on oral steroids. We will need to admit patients and give them IV steroids. We'll talk about that dosing later. If you've heard horror stories about Stevens-Johnson syndrome and mouth ulcers and things like that, that's a very rare occurrence. Just like that's a very rare occurrence for other things that cause Stevens-Johnson syndrome, like taking too much aspirin or other types of medications. The same thing applies for toxicities of the checkpoint inhibitors. Truly, Stevens-Johnson's and that dangerous skin slough is not common. So if that happens, if you have a rash and you have mouth ulcers or you start to notice blisters on your skin, you really need to present to your doctor immediately. And that's one of the things that it talks about on this toxicity management guideline, which is really helpful. The next thing I want to talk about, and it's also the next thing that appears commonly, is colitis or digestive issues. This can manifest all sorts of ways. The most common is obviously diarrhea. You can go more frequently. You can have your stools just be more loose. You can also have accompanying cramping or pain in your stomach that might happen before you go to the bathroom or might happen really all day. Sometimes patients will describe that they have a lot of bloating and a lot of gas, and they can kind of hear their bowels moving all the time. That's actually extremely common. And that typically, when we say colitis, that's what we're referring to. Now, patients can sometimes get inflammation of the upper part of their GI tract, in their stomach, in the small intestine. And that usually manifests a little bit different. It might be more acid reflux. It might be nausea. It might be that you're unable to digest your foods properly. Those are all things to kind of look out for. This toxicity in the single agent, Keytruda, Opdivo, Yervoy, happens roughly between like 15 and 20% of the time. In the combination, it's not necessarily that it happens more, it just happens to be more severe if that occurs. And that's really true for all of the toxicities that we're going to talk about tonight. When you combine Keytruda and Yervoy together, or Opdivo and Yervoy together, which is how it's prescribed and approved, a lot of times these toxicities aren't necessarily happening more, they're just happening worse. And that's really important because, you really need to be in tune with your oncology team or treating team so that you can really manage these toxicities fast. That's really the key. So let's say you have colitis. One of the things that's really important, and it's what we tell our patients in our clinic, is that diarrhea still happens commonly. So if you eat cabbage and noodles, or you have a hard time digesting chicken wings and you have that for dinner, you might get diarrhea the next day, and that can be totally normal. However, if you're having diarrhea from one of these agents, truly it's not going to act like regular diarrhea. So you're going to see that Imodium doesn't really help. Now, that's the first thing that we would tell you. Oh, you call in, hey, Melissa, I have diarrhea. I'm going to say, okay, have you tried Imodium? If you haven't tried Imodium, try Imodium. If you have bowel movements past a couple of doses of Imodium, most likely this is not just from chicken wings or cabbage and noodles. And in which case, we will sort of escalate our monitoring. So if your baseline is, say, 1 bowel movement a day, it's solid, no issues, no cramping, and now all of a sudden you're going 3 times a day, it's still semi-formed, we might watch you. Add, Imodium, add some fiber to your diet, avoid things like spicy foods, kind of go on a brat diet, which is bland, bananas, toast, oatmeal, things like that. And drinking lots of water. If you still continue to progress with diarrhea, or now your stools are a little looser, then we're starting to move into the management of this as an adverse event. So we're thinking about things like making sure we get you a stool culture, because other things can cause diarrhea that are infectious and not related to your immunotherapy. And actually then if we give you steroids to treat your immunotherapy and you actually had C. diff or Giardia, we actually will make that worse. So getting a stool culture is a pretty routine thing that we do in our clinic for patients that have diarrhea. If it's severe, like you're having cramping and things like that, a lot of times we will refer for a colonoscopy to really see the extent of the colitis, because even though the management would be oral steroids or IV steroids, somebody that has a colonoscopy and has just diffuse ulceration all through their colon, you're going to be extremely aggressive with, versus someone that may have just one patch of very superficial ulcers or no ulcers at all. So, really getting the GI team involved is extremely important in cases of colitis. But the things that, we can do is increase your fiber, make sure you're eating a bland diet, try Imodium first. If it doesn't work after a couple of doses, it's probably not going to work. Making sure you're drinking lots of fluids to avoid getting dehydrated, and obviously call your oncologist. The next most common thing is actually lung and breathing problems, or what we call pneumonitis. The reason that this has become extremely important, especially in the era of COVID, is a lot of these symptoms can mimic the same types of symptoms that COVID has. And interestingly, a lot of the agents that are now being used in the treatment of COVID, we use to treat, and have been using to treat pneumonitis. And one of those drugs is a drug called tocilizumab. It's a monoclonal antibody that's given IV. It's a drug that actually is specifically for patients that have pneumonitis that doesn't respond to steroids. So it works really great. But things that you would see if you have pneumonitis would be change in breathing, specifically shortness of breath. So you might find that normal activities like walking across your kitchen to get a drink of water might cause you to be short of breath, or, carrying a load of laundry up the stairs that never caused shortness of breath before could sometimes do that. In severe cases, it can cause shortness of breath in just casual conversation, and that can be really scary, especially for your family members. It can cause a dry cough that sort of almost sounds like irritative, where you're just kind of like like clearing your throat. Usually coughs from pneumonitis don't sound wet. It can progress to chest pain and severe shortness of breath. This is something that is diagnosed primarily with taking a pulse ox and seeing that the actual saturation of oxygen is low, but especially by imaging. So chest x-ray, CT scan will actually show these little areas of infiltrates in the lung, similar to COVID, that is actually your immune system responding to your lung. So you get these sort of patchy infiltrates. And actually I showed on my lecture on radiology that I just gave last month, an example of what pneumonitis looks like on a scan. So you can go back and check that out too. But that is primarily how that manifests, and the treatment for pneumonitis is steroids, just like all these other treatments. Now we might also add things like albuterol, nebulized breathing treatments to kind of open the airways if a person's having a really hard time, but really giving them steroids is going to fix this problem. Unlike the other toxicities where steroids kind of come into the management tree at grade 3, grade 2 pneumonitis, because you need your lungs, you need to breathe, and because of how quickly pneumonitis can kind of spiral downhill when you can't breathe properly, really we initiate steroids at grade 2. And also at grade 2, we would consider not giving you any more of these agents to avoid this coming back and really hurting you. So that is pneumonitis. And that happens in about like 10 to 15% of patients, which is still a very small percentage. Like one thing I always tell people that call into the line is think about the fact that there are 80% of people that this doesn't happen to. So the next most common thing that can happen is hepatitis or liver inflammation. And it's not infectious. It's not hepatitis C. It's actually your immune system attacking your liver cells. Most of the time, because patients are getting treated like every 3, 4, or 6 weeks, you will see this on labs before patients are having symptoms. Now, that's not always the case, but most of the time you'll see a trend in the liver functions. It's very infrequent that they go from normal to 10 times abnormal in one day. So a lot of times you'll see this trending before it's something that needs to be addressed. But things that you can see if you are having symptoms are things like aversion to eating, just not really being hungry, some nausea. You might have abdominal bloating, some pain, especially in the right upper quadrant, which is where your liver lives. You might see changes in your stools. Even though they might not have colitis, they might be lighter than they normally were. You might be extremely tired. Just an overall feeling of like, ugh, I don't feel good. So it's a kind of a vague presentation a lot of the times. But again, the liver functions will always be elevated in conjunction with feeling like poop. If you see yellowing in your skin, or you have severe right upper quadrant of the abdomen pain, those are reasons to really get your butt to the doctor as soon as possible, because that can be a sign of pretty severe liver damage. But again, it would be really unlikely that you would get there because somebody should be looking at your labs. Things that we kind of recommend for patients that do have these issues is to avoid alcohol for sure. Make sure you're drinking lots of water, because that'll help flush the toxins that your liver makes as a byproduct out of your system. Continuing to eat a healthy diet, and really to avoid things like Tylenol or other medications that are hard on the liver, some antifungals and things like that. So if you have this ongoing hepatitis problem that we're treating, you want to avoid the things that can hurt your liver more, because we really want to be on team liver and not do things that can hurt it worse. The next most common thing are actually endocrine abnormalities. And I kind of loop these or lump these all together, but this can be problems with your thyroid, either acting too good or not good enough, and your problems with your pituitary gland, which is the master gland. It sits right behind your eyes. And a lot of times this will give the most symptoms, because patients will complain of sort of like a pressure feeling behind their eyes or a vague sort of frontal or side headache. This is another thing that most of the time is picked up on labs prior to it causing symptoms. The exception to that a lot of times is adrenal insufficiency, because patients that are adrenally insufficient, because that's not typically something that is part of routine lab draws, patients will just be like, I am so tired and I'm nauseated and I don't feel like eating. It can progress to really severe nausea and vomiting, diarrhea, and just this overall feeling of malaise or just feeling terrible. That probably is the most common one that symptoms dictate drawing labs that then, will result in a diagnosis. But because endocrine glands give this sort of vague, changes in your energy, like being more tired and nausea and vomiting and headaches and dizziness, this can be really vague. And so these are the abnormalities that we actually look for when patients come in and they're like, I'm super tired, because fatigue is something that can be present in a vast majority of patients getting immunotherapy, that unfortunately, unless there's an underlying cause like thyroid dysfunction, pituitary dysfunction, adrenal dysfunction, we can't fix that very well. So we will look, when patients come in with a complaint of fatigue, we will look for all the explanations and rule them all out in the hopes that we find something, because unfortunately, if we don't find something, just having generalized fatigue is an extremely difficult thing to treat. I know that there have been a lot of symposium topics about fatigue and immunotherapy because I've watched them, that other centers have done through AIM's website. It's a really interesting piece of this puzzle that isn't really greatly explained. And so if you have fatigue from immunotherapy, certainly tell your doctor, because they should look at all these things to try to see if they can find a cause. And if they don't, there are some people that just get really overwhelming fatigue from these drugs. So reasons that you would want to immediately go to your doctor for these endocrine abnormalities would be if you literally can't get out of bed, or you feel like your heart is racing, or you feel like you have the worst headache you've ever had, or you start having visual changes. Those are all reasons that you really need to get on the horn to your doctor right away. But otherwise, these are things that would be pretty vague and probably picked up on labs. Kidney problems or inflammation of the kidneys can happen as well. You may notice that you have pain when you urinate up by the back of your ribs, because your kidneys actually sit real high. They're like way up here. So you might have pain up there when you pee. You might notice that you have darker than normal urine, or that your urine has blood in it. Those are all reasons to go to the doctor and let them know. Routinely, we do what's called a complete metabolic panel that's going to check for kidney function, but it doesn't always identify things in the urine like protein and ketones that would indicate like an early problem. So if you are having any changes in your urine, that's something that you would want to talk to your doctor about. This happens in like less than 5% of patients, even in the most severe cases. So this is not a common toxicity, but it is certainly something, that we see. And one of the things that you can do to protect yourself is making sure that you're drinking lots of water, and really being mindful of what your urine looks like on a daily basis. We've seen people that get these sort of vague mouth issues with like sores in their mouth, dry mouth, thick saliva, sort of like what's called stomatitis, which is just an inflammation of like the inside of your mouth. There are things that will be used, and they're mostly supportive care. So like mouthwashes, artificial saliva. We do use some steroid mouthwashes in severe cases. And Patricia, this is going to get posted to AIM's website and eventually to the From the Clinic to the Living Room site and the YouTube page. So you'll have plenty of time to go back and watch it. No worries. So these are things that are more are less likely to need steroid treatment and more likely to need supportive care, things like, using a gentle mouth care, things like toothpaste and mouthwash, making sure that you avoid things that have alcohol in it because they can make these symptoms worse, making sure that you're continuing to go to the dentist for your regular cleaning, avoiding like spicy foods. If those things don't help, antihistamine sometimes helps. We make a mouthwash. It's called Swish and Swallow. It has Benadryl, Maalox, and Benadryl, Maalox, and lidocaine in it that can help kind of soothe the mouth. We've had patients that have needed some steroid mouth rinses, but generally speaking, these things can be pretty easily taken care of. I'm going to run out of time. And then there's even more rare toxicity like diabetes, which is it acts almost like a type 1 diabetes. And you can develop things like musculoskeletal, like nerve inflammation, joint inflammation. That tends to be a little bit migratory, where you get pain here and then you get pain here and then you get pain here. Joint pain actually responds really well to injections, but we've seen patients develop carpal tunnel syndrome from immunotherapy. We've seen patients who have developed pretty severe neuropathy. Again, all of these things respond really well to steroids. In some cases where the joint pain and muscle pain is mild, we will try like a low dose of prednisone, which will allow the immunotherapy to still work, like 10 milligrams. But sometimes we need to get rheumatology involved and use things like Plaquenil to really, help us calm the immune system down so that it's not overreacting. Before I get to questions, because I did see a couple of questions, I just want to go over like the treatment. So essentially, if we decide that your toxicity is bad enough that you need steroids, that's something that your oncology team is going to initiate. There is a set 1 milligram per kilogram dose that's based upon your weight, and that's what you get per day. Some oncologists like to give it all at once in the morning. Some oncologists like to split that dose into 2 doses so that you're getting like pretty even coverage throughout the 24 hours. That's the way our clinic does it. It doesn't make it right. The recommendation is generally that you just get 1 milligram per kilogram per day. Patients that have like really bad sensitivity to steroids, sometimes given just the morning dose of prednisone is better because it doesn't keep them up, and that jitteriness will wear off enough that you can sleep. So that's one thing. If the steroids make you jittery, consider just talking to your oncologist about taking them just once in the morning as opposed to splitting the dose. We find that patients get better coverage of their toxicities by splitting the dose. So like, let's say you're a person who is 70 kilograms, or 60 kilograms, that's easier for math. You're going to split your dose into 30 milligrams of prednisone in the morning and 30 milligrams of prednisone in the afternoon. And that's where we would start. And the goal really of that high dose is to get this toxicity under control. So when you're having an adverse event, it's because your immune system's like, I need to attack everything. And we're not trying to shut it down and put it to sleep. We're just trying to like calm it down to a reasonable level so that it can calmly act and only attack the things that it needs to act. So when you give steroids, you're not shutting the immune response off when this happens. You're just making it be nice and level and calm so that it can do its job. And actually, many of our patients, some of which are listening, have had this happen and have had continued response to their treatment with tumor shrinking during their course of steroids. So that is one thing to keep in mind, that is not going to affect your response. So you start at a dose of 1 milligram per kilogram, you get the toxicity under control. The goal is to get it to go back to grade 1. So it might not go completely away, but you want it to get to a point where it's barely noticeable. And then you start to taper. And the one thing that's the most frustrating for patients is that you want to taper this really slowly so that you don't have to do this twice. So my dad and grandpa used to always say, do it good once and you never have to do it again. And so that's really our goal. So it's a slow taper. It's usually at minimum over 4 weeks sometimes, and most of the time it's over 6 weeks. For the example of it being 60 milligrams per kilogram, we would do, say, 30 milligrams twice a day for a week, and then your adverse event is at baseline. So then we're going to go 20 milligrams twice a day for a week, and then 10 milligrams twice a day for a week, and then 10 milligrams once a day for a week, and then stop. Really, once you get below 20 milligrams of total of steroid a day, you're no longer really suppressing the immune response, and at that point, that's where we tend to see things recur if they're going to. So we really take our time and taper slowly so that we don't, if, let's say, rash, because that's the easiest thing. If your rash goes completely away at the highest dose, and as you're tapering your steroids and you go from 20 milligrams twice a day to 10 milligrams twice a day, all of a sudden your rash starts to come back. We don't have to go all the way back up to 60 milligrams a day. We can go back to just 20 milligrams twice a day, which is where it was last controlled. So that's a really important thing, and why we taper so slowly, because 1, we don't want to do it twice, and 2, it allows us to not have to escalate back to the full highest dose to control the toxicity. Other things that we have to keep in mind with steroids is that we need to protect your stomach. So often, or all the time, while you're on steroids, we should be taking some type of, histamine blocker like Pepcid or famotidine. That really helps prevent the steroids from really irritating your stomach and causing a bigger problem. If the steroid taper has to last longer than really like 4 to 6 weeks, we may also do some prophylactic antibiotics, but that's really something that, most of the time we're getting off steroids before we would need to do that. If you did have other autoimmune toxicities or things that would make you more susceptible to infections, secondary infections, then that would be the individual decision to do that at that time. If for some reason steroids don't work, there are all kinds, and I mean all kinds, of immune modulating agents that can be used. For specifically tocilizumab is one that we use for steroid refractory lung issues. We use drugs like infliximab or Remicade for colitis that is refractory to steroids. So there are a lot of things that we can use that we didn't know about when these drugs were still in clinical trials to help you calm your immune system down to a more reasonable place. The other thing that people really want to know is, can I go back on treatment after an adverse event? And it really depends. It depends on which toxicity it is. The endocrine things, we usually just treat the problem either by supplementing your adrenal function, supplementing your thyroid, and you keep going. Those kinds of things tend to be less of a problem. A lot of the musculoskeletal things, hopefully we can get under good control and you can continue therapy. Things like colitis, pneumonitis, the liver function elevations, those are all things that really it's individualized. It depends on a whole lot of things. What grade your toxicity was, how quickly it resolved, whether other treatment options are available to you. So a lot really goes into that kind of decision, and it's not something that, we can really generalize. So hopefully this talk helped. Again, please check out these, toxicity management pages, because they really are helpful. There are other lectures that I've done that you can go back and watch, specifically the immunology lecture, if you need to understand more about the actual process behind this. I want to go back and look at some of the questions. They just keep kind of going back and forth. Why isn't cortisol part of the labs to head off hypophysitis? That's a really good question. It's so uncommon that it's not something that routinely is worth doing. So I know that sounds terrible because sadly, Nancy, you lost your pituitary function to immunotherapy, but it's not something that commonly happens. So it's not something that is routinely done. And also, it's something that symptoms will oftentimes tell us is occurring. So, drawing a random cortisol, because everybody's cortisol sort of releases at different times and can be extremely variable through the course of the day. It's not really a reliable screening test. Now, if you have symptoms of hypophysitis or adrenal insufficiency, it can certainly help. And there's actually a test that's definitive. It's called the cortisone stimulation test, and it's where you get a baseline level of cortisol drawn. It has to be done first thing in the morning. This is like a 7:30 a.m. test. And you get a baseline level drawn, and then they give you a drug called cortisone that is supposed to stimulate your adrenal glands to work. And then you get a blood draw at 30 minutes, 60 minutes, and 90 minutes. And what's supposed to happen is after that stimulant is given, it's supposed to raise your cortisol to a certain level. And if it doesn't achieve that raise, it actually is an indication of adrenal insufficiency, at which point it's replaced. But it's not like a level like if your liver functions are 205, you need to start steroids. Cortisol can, like my cortisol and my husband's cortisol at the exact same time of the day can be completely different, and his can be normal and mine can be exactly the same, and his can be normal and mine can be not. So cortisol is not like a very reliable screening tool, number one. And then hypophysitis doesn't necessarily mean that your adrenal function is going to be abnormal. So it could affect only one lobe of your pituitary and affect only your thyroid or only your sex hormones. So it's not really a good measure or screening tool for hypophysitis either. Really, truly symptoms like headache, significant fatigue, or if we see other abnormalities in the endocrine function, that is really what would clue us into hypophysitis. I hope, Nancy, that answers your question. Chronic side effects such as arthritis, those are tough, and they happen more late in treatment. It's something that can be extremely difficult to treat. We always, when these are refractory and tend to last even past the end of treatment, get in rheumatology involved. Not only to make sure that there isn't an underlying autoimmune disorder like rheumatoid arthritis or psoriatic arthritis or something to that effect, but also to just really get them involved because they have better drugs to treat it, like methotrexate and Plaquenil and things like that. So, chronic side effects like arthritis, if they're not well managed on, a really low dose of steroid, like 5 to 10 milligrams, really a rheumatologist should see you because they can really, really help. Debbie, your question says, I have a question regarding the COVID-19 vaccine. I'm post-Opdivo immunotherapy and I've had 2 Moderna shots. I feel my toxicities are worse. So this is a huge question mark that a lot of oncologists actually have. It's not necessarily that the COVID-19 vaccine should make your immunotherapy side effects worse. But what we do see, and this is, very logical, is that the side effects that people get from the COVID-19 vaccines are happening because it's upregulating your immune system. And the adverse events that you get from, in this case, Opdivo, are upregulating your immune system. And so sometimes when you do things that upregulate your immune system, it's like it hits that old Achilles heel. So other things that can cause this recurrent rash is actually seasonal allergies. So patients that have had especially Yervoy will complain that like every year now they get a rash when it changes from spring, into spring or into fall, when they previously never had that issue. So yes, that's a really common thing. Skin is actually extremely common, but it's not probably the Moderna shot that caused it. It's your own immune system's response to having it be upregulated that caused it. Let's see what else we got here. Sorry for getting my face so close. Patty, it looks like you had a similar symptoms. Are brand new spring allergies due to immunotherapy or the COVID vaccine? Probably, potentially both. But again, Nancy, it's related to really your immune system being upregulated, not necessarily because of the drugs. Thanks, Polly. I love you too. Wondering about genetic testing for melanoma. So this is something that is better talked about in a different lecture. And actually, Caitlin, if you want to contact me on the Ask an Expert site, AIM will actually post a link to that, but you can find it on AIM's site under Ask an Expert. You can contact me. We can talk about this more. But just to let you know, BRAF mutations are not hereditary. We actually did a lecture about the BRAF mutations a couple things ago, and you can find that on the YouTube site as well. That will go through BRAF and all of the things that you're asking in this little section. They don't adjust dose for IPI based on age, Sheila. That's something that actually, unless you have, I think the only dose adjustment that they will do is just delay the time between the doses. Melody says, I had random neuropathy once in a while before treatment, but got it horribly a couple months into treatment. You take gabapentin. So this is an extremely specific question, but things that can sometimes help with neuropathy, besides gabapentin, you could try Lyrica as well. Sometimes the dose of gabapentin isn't high enough. And then if that doesn't help, you need to see a rheumatologist because they can really help with those things. Robin, iritis is actually a problem that we just don't have time to cover, but disorders of the eye, really changes in vision, sensitivity to light, swelling in and around the eye. Those are all issues that can occur. If that happens, again, it's a more rare toxicity. It's something that an ophthalmologist should evaluate you. Eye drops for iritis will sometimes help, which are called prednisolone. If that doesn't help, oral steroids will. And really any type of thing that involves the eye is really important to make sure that it gets evaluated immediately. And it is something that might preclude you from getting further doses. And sometimes iritis or irritation of especially what's called uveitis can also be accompanied by colitis. So you want to be really mindful of your bowel movements as well. Natasha, mild allergies is a side effect. It may go away with treatment, but that may take some time because really it's due to the upregulation of your immune system. But again, it also can be reactivated as well, as I talked about before. Paige, we talked about it. Immunotherapy can definitely affect eyesight, but it's extremely rare. Gosh, there's so many things. Yeah, the only other thing that I can see when I'm quickly going through here is, Dave, you said you had a case of shingles. We have seen some people develop shingles during treatment. If you need to treat your shingles, you should do that. We do recommend that people kind of avoid any of the shingle shots during immunotherapy just because taking those types of vaccines can sometimes activate the immune system a little more than we'd like to see happen. Shingles happens. Shingles is actually a reactivation of an old infection. And so it's something that unfortunately, especially when the body is stressed, you can see shingles appear. So that's not an uncommon occurrence actually. I think I am going to cut off questions just because we ran way over time today. Of course, this is a topic that we could probably spend another hour talking about. If there are questions that you have about specific things to you, I try to avoid some of the questions that were a little too personal to handle on the air, but you can always reach me at the Ask an Experts page. I have a toll-free number. I also have emails. Form that you can fill out. We can get back to you. Please join us next month for May because May is Melanoma Month. We actually are going to be live twice that month. The first is on at the beginning of the month on May 12th. We're going to have a survivor come on. We're going to interview her. She's pretty cool. She has a really nice story. And then at the end of the month, we're actually going to be back with a webinar with Isabella Glitza from MD Anderson talking about brain mets and the emerging treatments for brain metastases and kind of walk you through I got diagnosed with brain mets, now what do I do? So it's going to be really, really interesting. So hope to see you at the end of May for that as well. I hope you all have a great night. Thanks for watching. If you need me, I'm here. Bye.